So today I'll be discussing testis pathology as well as bladder pathology. So first one will be common problems in testicular pathology, and I'll be doing this in somewhat of a differential diagnosis manner. Lesions that to me, but with my consults, I've seen that pathologists have problems with. So first one is a common situation, seminoma versus embryonal carcinoma. It's an important differential because they're treated differently and different prognosis as well. Now, this is the classic picture of seminoma, where we have nice clear cytoplasm, cells are relatively uniform, fibrous septa with lymphocytic infiltrate. So this is not a situation where anyone would have difficulty. And cytologically, the classic seminoma, again, uniform cytology, nice central nucleoli, not too many mitotic figures, again, not a problem. The difficulty is there is a variant of seminoma that used to be called anaplastic seminoma. It's also been referred to as high mitotic rate seminoma, where one can see a higher degree of pleomorphism. That can be a problem. And one of the features that you can recognize seminoma that's unusual is that some of these nuclei are square-shaped. So you can see they're kind of box-shaped. That's a classic feature of seminoma. But here we see an example of what in the past was called anaplastic seminoma. We don't use that term anymore because stage for stage, these seminomas that look more pleomorphic have the same prognosis as usual seminomas. But they are more difficult to recognize because they do have a much greater degree of pleomorphism than the typical seminoma. Cells are still loosely cohesive in contrast to embryonal carcinoma. Now, some of the patterns of seminoma that can also be somewhat confusing if one has not seen them is seminomas, although they're usually just uniform, diffuse, loosely cohesive sheets of cells, can sometimes form little cords of cells like lobular carcinoma in the breast, looking more kind of epithelial. And then another pattern is the pseudoglandular pattern of seminoma, which can be confused with embryonal carcinoma, where basically the cells fall apart and give a glandular appearance that can closely mimic embryonal carcinoma. But these are not true glands. These are still just seminoma cells falling apart and mimicking a gland. Here's another example of a pseudoglandular pattern in seminoma mimicking embryonal carcinoma. Another pattern of seminoma that can be confusing, and I have one of those in the slide seminar, is when seminoma has pagetoid spread into the rete testis. It can be quite extensive, where if one doesn't recognize that these are seminoma cells involving the rete testes, one could mistake these for glands as embryonal carcinoma. Here is embryonal carcinoma, typically much more pleomorphic than seminoma, more cohesive. They don't make glands, they make primitive tubular structures. And cytologically, embryonal carcinomas tend to have much greater degree of pleomorphism than seminoma or any of the other germ cell tumors. For example, yolk sac tumor also doesn't have this degree of atypia with these multiple irregular nucleoli, as much apoptotic bodies, mitotic figures, and necrosis. So cytologically, again, usually you can make this distinction. I don't use PLAP anymore as a germ cell marker. Also, Sol4 is another germ cell marker that's out there. I don't use Sol4. The more I've used it, I've realized it just stains a lot of other non-germ cell tumors. I think better is CD30, which will stain embryonal carcinoma, will be negative in seminoma. Keratins in general will stay in the embryonal carcinoma, negative in seminoma. Now, there are some pitfalls with immunohistochemistry that you have to be aware of. So both OCT3-4, which is a good germ cell marker, which is seminoma and embryonal carcinoma, are both positive. Seminoma can be c-KIT positive. And then CD30 is good for embryonal carcinoma, seminoma negative. The pitfall is typically, and most pathologists think that seminomas are keratin negative. However, sometimes you can see loosely cohesive cells of seminoma that are keratin positive, And some cases I've seen, there's actually been quite a lot of keratin positivity in still classic seminomas. So just be aware that although in general seminomas are keratin negative and brinal carcinoma is keratin positive, that's not always the case, and some seminomas can express keratin. Throughout, I'll have some pictures from various places that I've traveled. These are whirling dervishes in Istanbul. So another situation that one can encounter in seminoma is the presence of associated granulomatous inflammation. So it's very common in seminomas, about 25% of seminomas, to have these epithelioid histiocytes, these pink cells, admixed with seminoma cells. Most of the time, they're fairly not that extensive. It's not that much of a diagnostic problem. But in some cases, it can be this granulomatous inflammation can obscure or almost obscure the seminomatous component where it can be a diagnostic issue. So here's a case where we have a lot of granulomatous inflammation, which are these pale cells, these more delicate open chromatin histiocytes. And here we see a classic seminoma cell with a big prominent nucleoli. But what one has to also recognize is that seminoma cells are very fragile. And so it's very common for seminoma cells to undergo this pycnosis or very hyperchromatic smudgy chromatin, which are not going to be the same as what one would think of as a classic seminoma cell, but these are the seminoma cells you still have to be able to recognize. Here, if you do a C-kit, for example, you can highlight the seminoma cells amongst this very prominent granulomatous inflammation. Now, sometimes the intertubular germ cell neoplasia or intratubular seminoma can also develop a granulomatous reaction, which can mimic, or I should say mask, the germ cell neoplasia component. So here we see these granulomatous inflammation within tubules. They're within the seminiferous tubules, and they're reacting to the germ cell neoplasia in situ. Just like one sees granulomatous reaction reacting to the invasive component. Here's a situation where we have a very prominent granulomatous reaction within the tubules to germ cell neoplasia in situ, where for the most part it's almost impossible to even recognize where the germ cells are. It's totally obscured the germ cell component. So whenever you see a lot of granulomatous reaction within seminiferous tubules, you have to entertain the possibility that this could be a granulomatous reaction to germ cell neoplasia in situ. There's another entity called idiopathic granulomatous orchitis, which you can get a similar granulomatous reaction to normal germ cells, which enters into the differential diagnosis. But here, if you do again, this is a PLAP stain, you can highlight those germ cell neoplasia in situ cells associated with a prominent granulomatous reaction. This is from Jade Mountain in the Caribbean. So germ cell neoplasia in situ. It's basically seen almost always next to invasive germ cell tumors. And if you have only germ cell neoplasia in situ without an invasive germ cell tumor, and those patients are not treated, 50% of them will go on to an invasive tumor in 5 years. So classic germ cell neoplasia in situ, it only occurs in seminiferous tubules without spermatogenesis. So you, again, never see it in seminiferous tubules with sperm production. And you can spot germ cell neoplasia in situ even at low magnification. The nuclei stand out with these halos around the outside. They're always at the perimeter of these seminiferous tubules, again, lacking any sperm production. And in higher magnification, the Sertoli cells have the smaller nuclei, very delicate chromatin with a very small, uniform central nucleolus, whereas germ cell neoplasia, they'll have more irregular, prominent nucleoli and more hyperchromatic nuclei. Again, some of the germ cell neoplasia, just like seminoma cells, will be more smudgy and hyperchromatic. Here we see a little higher magnification, the distinction between Sertoli cells and germ cell neoplasia in situ. Multiple stains you can use. C-kit, I would recommend probably not using. It's not as specific. PLAP is a good stain for germ cell neoplasia in situ, but the one that I will use typically is OC34. It's cleaner, very specific, And so typically that's the stain. If I'm questioning whether there's germ cell neoplasia in situ, that's the marker I'll use. Now, one can also have other types of germ cell neoplasia in situ other than germ cell neoplasia in situ unclassified type. One can have commonly intratubular seminoma. So whereas germ cell neoplasia unclassified type is just a single cell layer of atypical cells around the perimeter of the seminiferous tubules, intratubular seminoma basically fills up the seminiferous tubules with these seminoma cells. One typically sees intratubular seminoma in cases with invasive seminoma, but one can see intratubular seminoma by itself as a precursor lesion without necessarily invasive tumor. One can also see intratubular embryonal carcinoma within seminiferous tubules. And a very common finding with intratubular embryonal carcinoma is this appearance where one sees the architecture of pre-existing seminiferous tubules with this very bright, dense pink, almost neon pink cellular necrosis. That's whenever you see this at low power, this bright pink necrosis in these tubular structures, that's intratubular embryonal carcinoma. It has a predilection for extensive necrosis. Here one can see a transition where one sees intratubular embryonal carcinoma with some calcification without as much necrosis, with some focal necrosis, and then finally what one often sees is just purely necrotic intratubular embryonal carcinoma. As with intratubular seminoma, most of the time when you see intratubular embryonal carcinoma, there is also invasive embryonal carcinoma, but occasionally this, again, can be a precursor lesion without invasive tumor. This is from Peru. Seminoma typically forms a mass lesion, but sometimes one can have what's called intertubular seminoma. Now, in terms of sizing of germ cell tumors, for most germ cell tumors, the size isn't critical, but for seminoma, it is a component of the staging. T1A versus T1B is less than 3 centimeters versus greater than 3 centimeters. So sometimes if you have intertubular seminoma, it's important to factor that component of the seminoma and recognize it for staging purposes. Most of the time when you see intertubular seminoma, it's accompanying invasive seminoma, but occasionally one can have only or predominant intertubular seminoma, and it can be difficult to recognize if you're not familiar what it looks like. Patients who have only or predominantly intertubular seminoma, they usually have no clinical signs of a testis mass. They often present either with infertility, cryptorchidism, sometimes large retroperitoneal mass, pain, or testicular atrophy. In gross examination, when you have a case of predominantly intertubular seminoma, there's no mass apparent in most cases, maybe at most just in the ill-defined firm areas with some discoloration. So intertubular seminoma, here we see basically seminiferous tubules. Some of them have some germ cell neoplasia in situ, and then in between the seminiferous tubules are these scattered seminoma cells associated typically with a lymphocytic infiltrate, but no mass-like lesion. Sometimes these can be very sparse intertubular seminoma cells, where one can see just few scattered seminiferous cells in an otherwise, as in this case, an atrophic testis. Another case with just sparse intertubular seminoma cells where the surrounding testis shows prominent intertubular seminoma. So the time I start looking for intertubular seminoma is usually in cases where there's very extensive germ cell neoplasia in situ. That's the typical scenario where you'll see this microinvasive intertubular seminoma. The other clue to looking for intertubular seminoma, in addition to having extensive germ cell neoplasia in situ, is that low magnification. If you see an area with a lymphocytic infiltrate, that's something you want to go to higher magnification to look for, because in the normal testis, one would not expect to see a lymphocytic infiltrate. And when one goes to higher magnification on the lymphocytic infiltrate, then you can recognize the scattered intertubular seminoma cells. This is from Australia. The next topic I'll be talking about is spermatocytic tumor. We used to call them spermatocytic seminoma, but as I'll talk about, there's virtually no similarities between seminoma and spermatocytic tumor, so the name has been changed. So just to compare the two and show how different they are, seminomas typically second to fourth decade, but one should recognize you can get seminomas. There's a second peak of seminomas in men in their 50s. We tend to think of seminomas typically in 20s and 30s, but they can occur older. Spermatocytic tumor is typically older individuals, but I, for example, have seen a spermatocytic tumor in a 20-year-old, so there can be overlap. These are general categorizations. Seminomas, we can see them in extragonadal sites. We might call them dysgerminomas or germinomas, but we can see them up and down the body in the midline in many sites, where spermatocytic tumor only occurs in the testes. As I talked about, it's common to see granulomatous reaction to seminoma. We don't see that in spermatocytic tumor. I'll talk about syncytial trophoblasts accompanying seminoma, where it can be difficult to tell versus choriocarcinoma. Whereas spermatocytic tumor, you don't have syncytial trophoblasts. Germ cell neoplasia unclassified, which we just went over, very common in seminomas, not seen in spermatocytic tumor. OCT3-4 or OCT4, positive seminomas, negative spermatocytic tumor. And a gain of isochrome 12P, which it's not something we do typically as a diagnostic test. Occasionally we will do that FISH to look for isochrome 12P amplification, but you don't see that in spermatocytic tumor. And then from a treatment and prognosis standpoint, which is most critical, seminomas, if they're more advanced stage, you need adjuvant radiation therapy or chemotherapy. Spermatocytic tumor, the entire treatment is just orchiectomy. Seminomas can metastasize, obviously, where spermatocytic tumors have no potential to metastasize. And it's actually striking because as we'll go through the histology of spermatocytic tumors, they're actually very pleomorphic and much more pleomorphic than seminomas. But despite their pleomorphism, again, they just do not metastasize. The only exception, and this is exceedingly rare, is spermatocytic tumors. There are rare case reports of at the time of presentation, at the time of initial orchiectomy, the spermatocytic tumor is accompanied by a sarcoma, either an undifferentiated sarcoma or in some cases rhabdomyosarcoma. Only in that setting is there a potential for metastases. But if there's a pure spermatocytic tumor at the time of orchiectomy, it'll never metastasize. You never develop a subsequent sarcoma. So at low power, spermatocytic tumors often have a myxoid, a mucinous kind of matrix, and you can appreciate that even in the gross. And so you can often see these kind of acellular, myxoidy, mucinous pools in spermatocytic tumor, not something you'd see in a seminoma. And then the classic findings in spermatocytic tumor is 3 cell types. The 3 cell types are not evenly distributed. The most common cell type is the intermediate cell type. And the intermediate cell type has a very delicate, what's called spiremic chromatin or leptotene chromatin. It's analogous to primary meiosis, where you get this the mitotic figures basically, or the chromosomes dispersed in this speckled pattern. Sometimes these speckled intermediate cells in spermatocytic tumors, you don't see nucleoli, but you may also see fairly prominent nucleoli in addition to the speckled chromatin. So that's the most common cell type. Least common are giant cells. In some cases, you may not see those giant cells. And then the third most common pattern is, to me, it would look like erythroblast. Their nuclei are almost like lymphocytes, but they still have this rim of pink cytoplasm. So whereas seminomas are more uniform population of cells with vesicular nuclei, central nucleoli, here we have these 3 cell types. Seminomas have clear cytoplasm full of glycogen. Spermatocytic tumor has this dense eosinophilic cytoplasm, another differentiating feature. Here we see, again, the 3 cell types, the intermediate cell type, larger cell type, and then the smaller lymphocyte-like or erythroblast-like cell type. A little higher magnification just to show the cytology. But you can see they can have very irregular nucleoli. They may have frequent mitotic figures as well. Now, as you recall, I said you do not get germ cell neoplasia unclassified type in spermatocytic seminoma. But what you do see is intratubular spermatocytic tumor. So the distinction is you don't see those cells that look like seminoma cells as a single cell layer around the outside of the seminiferous tubule, which is what you see with germ cell neoplasia unclassified type. What you see are the classic cells of spermatocytic tumor, speckled chromatin, the small erythroblast-like cells, filling up seminiferous tubules. That is acceptable for a spermatocytic tumor and not uncommon. Just to contrast, this is seminoma with the more open chromatin, cleared cytoplasm, a uniform population of cells, not the 3 cell types that we talked about. Now, not all, about 85% of seminomas have a lymphocytic infiltrate, but recognize that there is a minority of seminoma where you may not see lymphocytes. It's not always present. I've also seen, even though typically spermatocytic tumor you do not see lymphocytes, I have seen examples of spermatocytic tumor which can have a lymphocytic infiltrate. So that's one feature that may overlap between the two. Here, a little higher power of typical seminoma. This is from China. So another issue, common differential diagnosis in testicular pathology that has significant implications is whether there's lymphovascular invasion present or whether it's just artifactual tumor in vessels. So the majority of studies have shown that lymphovascular invasion correlates with a more advanced stage, such as lymph node metastases or recurrence. Most of these studies don't discriminate between lymphatic invasion or venous arterial invasion. So we don't, when we're looking at a testis, all we basically look at is lymphovascular invasion, and we don't distinguish between the two. The importance of lymphovascular invasion comes into staging of germ cell tumors. So stage PT1 is tumor limited to the testes without lymphovascular invasion. To PT2, there are several different criteria that would result in a staging of a PT2. Lymphovascular invasion by itself would make it PT2, or if the tuna goes through the tunica albuginea, which is uncommon, which is PT2. And then the other common situation that leads to a PT2 is when the tumor invades hilar fat and epididymis. So it's usually either lymphovascular invasion or involvement of hilar fat or epididymis that results in PT2. And then PT3 is spermatic cord involvement. And that sounds straightforward, but actually it's not, because the question is, when does the spermatic cord actually start? So what I typically do is take sections from the hilum of the testes and then take sections higher up where you're above the top of the testes. So your section has both vas deferens and the soft tissue of the spermatocord. And at that level, if I see tumor in the soft tissue next to the plane of the vas deferens, I would call that spermatocord involvement. If you have soft tissue involvement closer to the testis, stay in the same plane as the testis, to me that's hilar involvement, not spermatocord involvement. So what are the pitfalls in identifying lymphovascular invasion? One is it's not that uncommon, as I'll show you, to have histiocytes in the cord vessels without tumor cells. Very commonly, one can see artifactual displacement of loose tumor cells in vessels. And the best place when you're trying to look for true lymphovascular invasion is at the periphery of the tumor and in the tunica albuginea. So this is a not uncommon situation in the spermatocord, either in your spermatocord margin, or you should also take a section of the mid-spermatocord. One can see a collection of histiocytes in the spermatocord. Whenever you see this, you want to look at higher magnification and sometimes do special stains, because in some cases these are only histiocytes, but in some cases there are scattered tumor cells amongst those histiocytes, which would account for lymphovascular invasion in PT2. So if you see lymphovascular invasion in the spermatocord, it is PT2, not PT3. PT3, you need to see invasion into the soft tissue of the spermatocord. Here's a CD68 showing they're all histiocytes, and there was no staining. Staining was done for OCT3/4. There was no tumor cells. But here's another case where we see histiocytes in the spermatocord vessel. And again, you have to look very carefully and see, is there any tumor cells? So here, there's nothing that I can recognize definitively as a tumor cell. But when you look a little bit more carefully, Most of these look like histiocytes, but you have to say, what is this cell? Could that be a histiocyte? Could that be a tumor? Maybe that could be a histiocyte, could be a tumor. In cases where you're not sure, then you should be doing stains for example, OCT3-4. Here's a case where we have overt seminoma in the spermatocord vessels, which would be PT2. Higher magnification. This one you don't need stains. This is typical seminoma cells. But if you weren't sure, an OCT3-4 would label those cells, and that would be diagnostic. So what are the morphological features of true lymphovascular invasion, but as opposed to artifactual vascular involvement? One is that it involves the lymphovascular structure lined by flattened endothelial cells. But you want to make sure typically that the cluster does not conform to the exact shape of the vascular structure. So if you have a vascular shape that looks like a dumbbell and the tumor in it looks like a dumbbell, that's just retraction of tumor, not true tumor thrombus. What I also look for is a fibrin thrombi associated with the tumor cells. That means it's more real. It's elicited a reaction. Also, you look for mural attachment. That tells you, again, it's real, not artifact. And if you see, sometimes you'll see re-endothelialization over the tumor thrombus. Again, that's real, not artifactual. The other thing I will do, and I'll show examples of this, is when you're assessing whether something is true vascular invasion or an artifact, just look at low power to see how much background artifactual deposition of germ cell tumors all over the place is present. So in a case where you see displaced tumor cells on the outside of the tunica, all over the slide, those are cases you want to be more cautious calling vascular invasion. Typically, true vascular invasions, the cells are going to be more cohesive. They'll have a more rounded edge as opposed to just loose cohesive cells with artifactual displacement. And then the other thing is sometimes just to look at the cluster and say, is the architecture of that cluster different than surrounding tumor? So these are some examples of true vascular invasion. So the trickiest situation to identify vascular invasion is with seminoma. The seminoma are loosely cohesive cells. So when they're in a vessel, even with vascular invasion, the cells will be loosely cohesive, and therefore it's harder to tell versus artifactually displaced loosely cohesive cells. So for me, the threshold to calling vascular invasion seminoma is elevated. I have to be sure it's a true tumor thrombus. Here we see invasive seminoma on the upper right. These are loosely cohesive seminoma cells, but you can see that these are covered by an endothelial layer. So the fact that there's this endothelial layer and that the seminoma cells are attached to the wall of that vessel, that's indicative that this is true vascular invasion. Here's the invasive seminoma component. Here we see in a vessel that we have a histiocytic reaction. So there's some reaction here within these vessels, and then you want to look carefully to see what's in that vessel. And when you look closer within all those histiocytes, either all these histiocytes, but then these are these hyperchromatic pycnotic seminoma cells that I talked about before. Don't always expect that when you're looking for seminoma cells associated with histiocytes that you will see these nice classic seminoma cells with prominent nucleoli. They can often be these mummified hyperchromatic nuclei. This is also a hyperchromatic seminoma cell here as well. Probably a seminoma cell, probably a seminoma cell, probably one here with squared off edges. But this would be a case that would be expected, I would say, to do special stains to verify or to determine whether there are seminoma cells there. And when you do the OCT3-4, you can see that it's very sparse, but there are scattered seminoma cells here in this granulomatous tumor thrombus, which is a real tumor thrombus, because artifactual, the displaced tumor cells, you wouldn't see this granulomatous reaction. Here's another case of true vascular invasion. It's attached to the wall, and you can see even at low power these seminoma cells there. Now here's a case where there's extensive tumor in spaces that conform to the shape of lymphatic spaces. This is the invasive tumor that has a different architecture. So the invasive tumor is not composed of these rounded nests. So the fact that we see these rounded nests within spaces also indicates that this is true vascular invasion in a seminoma. Yes, the reason why this is not artifactual is if it was artifactual, they wouldn't be these rounded nests in here. It would be more just loose individual cells. So something like this could be artifactual, I'm not sure. But the fact that these are more cohesive, rounded structures, to me indicates more that these are real.
And when is in Dutch, should we do CD34 or factor 8 to identify the...
Yeah, if you're not sure that these are true vessels versus retraction, absolutely. You could do an ERG or CD31 or 34, absolutely. This is embryonal carcinoma. Embryonal carcinoma is, I think, a little easier to tell versus seminoma, artifactual. But also, even with embryonal carcinoma, you want to make sure that it follows the same criteria, either being attached to the lumen, has a thrombus associated with it, reendothelialization. But here you can see the vessel on the outside. There's a blood clot that's undergoing organization with this embryonal carcinoma associated with it. So that tells us it's been there for a while and that it's a true vascular invasion. Higher power of a different case of embryonal carcinoma, the association of this fibrin, this pink amorphous material, tells me that this has, again, been there for a while and that this is real, not just artifactual. Another case of embryonal carcinoma, which undergoing fibrin and organization of the fibrin, so a real tumor thrombus. So in contrast, artifactual involvement, it can be quite extensive. This is on the outside of the testis, and you can just see all these loosely cohesive cells everywhere, but it's kind of a pitfall, an unfortunate pitfall, that tumor cells tend to involve empty spaces. They just gravitate to empty spaces. So one can see extensive artifactual tumor in vascular spaces, but in the setting of seeing the artifactual tumor cells outside and not in vascular spaces, one would not call this true vascular invasion. That's artifact. This is also artifact, again, outside the testes. You can see just loosely cohesive individual cells, the same cells just sitting there in a vessel artifactually. Basically, the same situation with embryonal carcinoma on the outside of the testes, artifactually in vessels. This is from Cappadocia in Turkey. So as I mentioned, another common problem in testis pathology is syncytial trophoblast versus choriocarcinoma. So it's very common to see scattered syncytial trophoblast in seminoma, but you can see it in other germ cell tumors as well. One of the things that you see with syncytial trophoblasts is they tend to cluster around blood vessels. They have no cytotrophoblasts, and you won't see necrosis, whereas typical choriocarcinoma, by definition, not always, but usually will have cytotrophoblasts. There are monophasic choriocarcinomas where you don't necessarily have both cytotrophoblasts and syncytial trophoblasts, but the vast majority of choriocarcinomas you'll see both. And often choriocarcinoma has hemorrhagic necrosis as well. Syncytial trophoblasts can elevate the serum HCG in the hundreds, and if you have extensive number of these syncytial trophoblasts, it can even be in the low 1,000s. Choriocarcinoma, typically HCGs will be in the tens of thousands, hundreds of thousands, but it depends on how extensive the choriocarcinoma is. So this is an example of a seminoma with extensive syncytial trophoblasts. We don't see any cytotrophoblasts. The cells around the syncytial trophoblasts are just these loosely cohesive seminoma cells. But, a lot of these syncytial trophoblasts, that would bump up this serum HCG. And so it's important to report these because the clinician will then correlate your findings of syncytial trophoblasts with a minimally elevated HCG. It'll reassure them that there is no choriocarcinoma in the specimen. Here's a case of syncytial trophoblasts encircling blood vessels, and that's, again, where they commonly are seen in a seminoma. Here we see another case where we have blood vessels and these syncytial trophoblasts encircling these blood vessels.
So this could be considered vascular invasion?
No, I wouldn't call that vascular invasion. They're basically more rimming, kind of the outside of the vessels as opposed to being in the vessels. This, I think, highlights that. If you do HCG stain, in a case with syncytial trophoblasts, you can see how nicely they're encircling these blood vessels. but not invading the blood vessels. One can also see vacuolization in syncytial trophoblasts. It's a morphological variant of syncytial trophoblasts. It can be more difficult to tell choriocarcinoma versus just isolated syncytial trophoblasts in the setting of embryonal carcinoma, because embryonal carcinoma cells can resemble cytotrophoblasts. The difference is embryonal carcinoma tends to be much more pleomorphic, these cells, whereas cytotrophoblasts, the cells have a lighter, grayer cytoplasm, as I'll show you in a subsequent slide, and the nuclei are not as pleomorphic as embryonal carcinoma. But in cases that you're not sure, is this embryonal carcinoma plus syncytial trophoblast, or is this choriocarcinoma? A few stains that you can do. One is you can do GATA3. GATA3 is a good trophoblastic, cytotrophoblastic marker. It would be positive in cytotrophoblasts, negative in embryonal carcinoma. Conversely, you can do CD30, which would stain the embryonal carcinoma, be negative in the cytotrophoblasts. Here's the case showing the OCT3-4 staining the embryonal carcinoma and not the syncytial trophoblast. From the previous case showing that this is embryonal cancer plus syncytial trophoblast, not choriocarcinoma. Another case of embryonal carcinoma with the syncytial trophoblast with the OCT3-4 staining. HCG will not light up the embryonal carcinoma cells, so that's another marker that can be useful. And then CD30, as I mentioned, will highlight that you're dealing with embryonal carcinoma, not cytotrophoblast, and the syncytial trophoblast will be negative for CD30. In contrast, choriocarcinoma, many patients present with widespread metastases. As I mentioned, HCG extremely elevated, often advanced stage, poor prognosis. But one thing that pathologists are not as familiar with is stage for stage, choriocarcinoma has a similar prognosis. The reason why choriocarcinoma overall has a poor prognosis is they typically have a vascular permeation early on in their course and spread early on in the course. But we did a study on small choriocarcinomas, which are uncommon, microscopic, tiny choriocarcinomas, and most of those patients were cured and had a good prognosis. So classic choriocarcinoma is a dimorphic population. You have these multinucleated syncytial trophoblasts with this very amphiphilic dark purple cytoplasm. The cytotrophoblasts, as I mentioned, have kind of a lighter grayish, dusky purple cytoplasm, not as densely purple as the syncytial trophoblast, and not as pleomorphic as embryonal. They have multiple nucleoli, but not irregular nucleoli. The shapes are not as pleomorphic. You won't see as many mitotic figures. They're relatively more uniform cells. Another example of choriocarcinoma with these syncytial trophoblasts, which sometimes can get kind of smudgy and somewhat pycnotic with abundant cytotrophoblastic cells. Sometimes in choriocarcinoma, the syncytial trophoblast can be relatively inapparent if you not know what you're looking for. Here we see all of these cytotrophoblasts, and then the syncytial trophoblasts are just capping the cytotrophoblasts with these multinucleated cells just draped over the surface of them, but again, not as apparent as the prior cases that I showed. As I mentioned, choriocarcinoma, the typical diathesis is that low-power hemorrhagic necrosis. It's very common in germ cell tumors to see necrosis. Even seminomas can have a lot of necrosis, but this combination of hemorrhagic necrosis is typical of choriocarcinoma. So whenever you see hemorrhagic necrosis at low power, that's when you want to go down and say, could there be choriocarcinoma there? As I mentioned, sometimes you can have a small choriocarcinoma. This was the only choriocarcinoma in the entire case, literally just a couple millimeters. But what one sees, perfect combination of syncytial trophoblasts with these cohesive admixed cytotrophoblasts. This is from Vietnam. So let me now turn to differential diagnosis of necrosis in testes. So as I mentioned yesterday with one of the slide seminar cases, it's important whenever you have necrosis to say what type of necrosis it is. Is it coagulative necrosis, an infarct? As we'll see, the common scenario that you see that in the testis is either going to be vasculitis or with torsion. And the difference is that if you have vasculitis, the infarct will be focal in the testis. With torsion, you twist the cord, you compress the veins. The entire testis is by definition necrotic. If you see cellular necrosis, that's tumor necrosis. And then caseous necrosis would be, for example, tuberculosis. So necrotic seminomas is basically the same age range as regular seminoma. And it's just like the case I showed you yesterday. This was a case where actually a pathologist did not recognize that this was tumor. And unfortunately, the patient developed metastasized and it became a medical legal problem. But what one sees here at low power is dead tissue. And so you want to look more carefully at that dead tissue to say what is the nature of that dead tissue. And you can see that even though it's not well preserved and the tissue is dying, you can still make out the cytology. These are seminoma cells. Even though it's necrotic, you can actually make a diagnosis of necrotic seminoma. In this case, you could even see that there was intertubular dying or necrotic seminoma cells in between. Higher magnification. If you look carefully, these are not any normal Leydig cells. These are seminoma cells in between the seminiferous tubules. Another case of necrotic seminoma. This one is a little bit more necrotic. It's harder to appreciate that these are seminoma cells. You wouldn't be able to make a specific diagnosis, but you should definitely be able to get to the point that this is necrotic tumor. As I mentioned yesterday, sometimes you can do special stains like OCT3/4 to try to identify what's the nature of the necrotic tumor, but sometimes you just may be able to say there's cellular necrotic tumor. In this case, we did an OCT3/4, and despite the tumor being not well preserved, it's still labeling. It doesn't tell you it's embryonal carcinoma or seminoma. Both would be OCT3/4 positive. Now, in contrast, torsion can occur in two different settings. There's what's called neonatal torsion, where kids either have in utero torsion, twisting of the testicle, or twist basically shortly after birth. But it's always going to be within literally weeks to a month after when the child is very young. That's called neonatal torsion. And the other time frame that you see torsion is in adolescence. Neonatal torsion, there's no anatomical defect, it's just bad luck. The testis just twists. Because basically, early on in utero, the testis is not attached to the tunica. It's much more flexible. And for no apparent reason, in some neonates, it can just twist in an infarct. Typically, what happens when, after birth, the testis gets fixed up against the tunica so it can't twist. But in some adolescents, there's a defect. It's called the bell clapper defect, where the testis is not fixed. And in that situation, it can twist and cause torsion. And when you have torsion, as I mentioned, the entire testis is necrotic. It's a hemorrhagic necrosis because the veins are first compressed. The arteries is the thicker wall. It's still pumping out blood when the veins are compressed, so it leads to just this massive diffusion of hemorrhage amongst the necrotic tissue. And what you see with torsion is just totally dead tissue. Now, when you see an infarct in the testes, it can typically affect third and fourth decade, but it can be older patients. Most of them have what's called polyarteritis nodosa-like vasculitis, which I'll illustrate. If you see a granulomatous vasculitis, those are the ones more likely to be associated with a systemic disorder like polyangiitis, granulomatosis, or Churg-Strauss. So 80% of patients with polyarteritis nodosa-like vasculitis and 4% with granulomatous polyangiitis will have testicular involvement. So this is what you get with an infarct in the testis. It's a localized area, just like an infarct anywhere else, a hemorrhagic rim. And then anytime you see an infarct in the testes, you should always look for the vasculitis. And the vasculitis is typically going to be around the tunica albuginea. And what you're looking for classically is a bright pink fibrinoid necrosis of the vessels. That's polyarteritis nodosa-like vasculitis. They'll stand out at low power. And if you look at higher power, PAN-like vasculitis, typically involves only a portion of the vessel. So here we see a relatively preserved portion of the vessel wall. Then we have very abrupt fibrinoid and necrotic vessel wall here. Another example of the vasculitis, again, normal vessel wall, and then you have this fibrin deposition indicating the damaged vasculitis. Within the vasculitis, often you'll see a lot of karyorectic debris. And then this, in contrast, is a granulomatous vasculitis. So when I see a granulomatous vasculitis, so if I have a polyarteritis nodosa-like vasculitis, what I will end up putting in a note saying this is most likely is restricted to the testes. However, the patient should be evaluated for systemic vasculitis. If I see a granulomatous vasculitis, like we see here, lymphocytic granulomatous vasculitis, I will say these vasculitis are more associated with a granulomatous, systemic granulomatous disease, like I mentioned, polyangiitis with vasculitis or Church-Strauss, and patients should be evaluated for that. Another case of granulomatous vasculitis associated with an infarct. Infectious necrosis, the key thing with any infections involving the testes, it always affects the epididymis first. So if you do not see epididymal involvement, it's not an infection of the testes. Also, there's a distinction when we looked at the granulomas associated with seminomas. They're not discrete little cannonballs of granulomas. They're more ill-defined granulomatous inflammation, not discrete round granulomas. When you get infectious granulomas, they tend to be more well-defined. So, for example, this is the case of tuberculosis involving the testes. You can see these more discrete, rounded granulomas with caseous necrosis. A little higher magnification. And this is from Petra in Jordan. So now let's turn to teratoma, and I'll show some examples in the slide seminar as well. One issue with teratoma is teratoma versus glandular yolk sac tumor. So one can see, and I'll show an example also in the slide seminar, a glandular yolk sac tumor. Sometimes yolk sac tumors amongst all testicular tumors can have them kind of a myriad of patterns. So with seminomas and brinal carcinomas, choriocarcinomas, most of them are relatively similar one to another. Yolk sac tumor, there's hepatoid patterns, there's glandular patterns, polyvesicular vitelline patterns, microcystic patterns, etc. So one of the patterns is enteric or glandular pattern, which is similar, where you have multiple tubules. One of the key features to recognizing, two features to recognizing glandular yolk sac tumor is one is the subnuclear clear vacuoles is a characteristic feature of glandular yolk sac. The other characteristic feature are these dense pink inspissated secretions, which are often AFP positive. Here we see another glandular yolk sac. The other thing to note in glandular yolk sac is it lacks a smooth muscle around these little tubules. Now, there's several different stains that one can do for yolk sac tumor. Everyone knows alpha-fetoprotein. The problem with alpha-fetoprotein sometimes is the whole slide can be brown because patients will have elevated serum AFP. And sometimes it can be a dirty stain to interpret. Here, we can see that the epithelium is staining more intense than the background, so it's still positive. But sometimes it can be difficult. Glypican 3, I think, sometimes is a cleaner stain for yolk sac tumor, and stain I prefer. In contrast, this is teratoma. And what one typically sees with teratoma in germ cell tumors is that it will not have the subnuclear vacuoles, it will not have the dense pink secretion, and typically it will have a muscle collarette around those glands. Another differential with teratoma is atypical immature glands in a teratoma versus somatic malignancy. So it's not uncommon in post-pubertal type teratomas, which are malignant teratomas, to see cytologic malignancy or atypical glands in the teratoma. So if this were, for example, in the colon, this would look like colon cancer, or lung, it would look like cancer. But if you just see isolated glands that have malignant features in a teratoma, it's just part of the teratoma. You don't mention it. It's still part of post-pubertal teratoma. Similarly with the mesenchymal component, it's not uncommon to see cartilage that looks like chondrosarcoma. But if it's just small foci of cartilage that have this appearance, it's just part of post-pubertal teratoma. You don't mention it. One can also see, for example, small foci that look indistinguishable from rhabdomyosarcoma, but if it's a limited focus, less than a 4x field, it's just part of the teratoma. Again, no need to mention. Very commonly in teratoma, what one can see is that around some of the glands, one can see this very cellular stromal component that basically looks like sarcoma. Highly cellular, highly mitotically active. It's basically in situ sarcoma. It's cuffing the glands, and as long as it's not sheeting out greater than a 4x field, it's, again, just part of the postpubertal teratoma. You don't mention it. In contrast, somatic malignancy in a teratoma is when you have one of the components, it could be epithelial or mesenchymal, where it outgrows and displaces the other components of the teratoma. And the definition, the latest WHO definition is greater than 5 millimeters. Basically, the older definition was larger than 4x field. They both translate to basically the same, so for the most part, you can use either one. The most common somatic malignancies, so when we talk about a somatic malignancy, we're talking about a tumor that typically does not occur in the testes. It's not a germ cell tumor, not a sex cord stromal tumor. It's a tumor you would see somewhere else in the body, in a child or in an adult, but it's arising in association with a teratoma. The most common ones are what we used to call PNET, primitive neuroepithelial tumor. I probably should change the slide. We now call them ENETs, embryonic neuroectodermal tumors, because they are different than, in some respects, from PNETs, and rhabdomyosarcomas. But basically, I've seen every type of germ cell tumor that can be present, a non-germ cell tumor that you can see in a teratoma. You can see them, the somatic malignancy primary in the testes when you first get the orchiectomy, or you can also see it in the metastases, even if it wasn't in the primary, especially after chemotherapy. The importance of somatic malignancies in a metastatic site is it typically does not respond to germ cell tumor chemotherapy. If you have a somatic malignancy confined to the testes, usually that's not as much of a problem. But if and it spreads to the retroperitoneum where the surgeon can get around it, and it's resectable, again, that's not much of a problem. But if it's unresectable, it's wrapping around the veins, major veins and artery, or in the mediastinum where it's not resectable, those end up being lethal disease. Another we'll talk about in the slide seminar is yolk sac that can show sarcomatous features, and I'll discuss that later. So this is a case of what used to be called PNET, now we're calling embryonic neuroectodermal tumor. So the embryonic neuroectodermal tumors that arise in association with teratomas have a very characteristic morphology. They look like CNS PNETs and not like soft tissue PNETs. They are characterized by these prominent tubular rosettes with these primitive immature neuroepithelial cells. The other common pattern that we see is, as I mentioned, rhabdomyosarcoma. And so you can see, for example, these immature neuroepithelial components very focally in a teratoma, and as long as they're focal, less than a 4x field, again, you don't mention them. It's only when they sheet out greater than a 4x field, then you say there is a somatic malignancy arising in a teratoma composed of embryonic neuroectodermal tumor, or there is somatic malignancy arising in a teratoma composed of rhabdomyosarcoma. These look just like rhabdomyosarcomas in any other site. Another common type of somatic malignancy is the embryonic type tumors. For example, this is a case of a Wilms tumor arising in a teratoma. One could see neuroblastomas arising in a teratoma. This is an example of an adenocarcinoma arising in a teratoma, where this is sheeted out greater than a 4x field. This was a case of a papillary carcinoma that sheeted out greater than a 4x field, somatic malignancy arising in a teratoma. So another differential, and we'll talk about this also in some depth in the slide seminar, is epidermoid cysts versus prepubertal type teratomas, which are benign, versus postpubertal type teratomas, which are by definition malignant. So an epidermoid cyst, very simply, is a cyst with keratin. Key thing is the surrounding seminiferous tubules should look normal with active somatogenesis. A dermoid cyst, you have other elements, skin adnexal structures like hair, sebaceous glands, sweat glands. In a prepubertal type teratoma, is something that has changed over the last maybe 10 years or so. It used to be that any post-pubertal any teratoma occurring in a post-pubertal male was malignant. Now we recognize that uncommonly, it's still pretty uncommon, that in a post-pubertal male, one can have a pre-pubertal type teratoma that is benign. So in the past, it was somewhat easier to practice. When I was in residency and early on in my faculty, any post-pubertal male that had a teratoma was malignant. That was the definition. Now we can't say that. We have to look at the teratoma and decide, is it a post-pubertal type, which is malignant, or pre-pubertal type, which is benign, even if it's a post-pubertal male. So what does a pre-pubertal type teratoma look like? They're often very cystic. So you often will see multiple keratin cysts, not a single keratin cyst like an epidermoid cyst, but multiple. You often have a ciliated respiratory type epithelium with smooth muscle. It's very organoid, trying to recapitulate the normal structures that we see in the body. You should have no cytologic atypia. So, for example, the glands that I showed that look like adenocarcinoma, you should not see that in a prepubertal type teratoma. By definition, there's no germ cell neoplasia in situ in the surrounding testes. You shouldn't see any microlithiasis, which is something that you often see with germ cell tumors. You shouldn't see scarred areas, which might be a regressed germ cell tumor. And you shouldn't see widespread tubular sclerosis or atrophy in the testes. And by definition, they lack isochrome 12p amplification. And in some of these cases, we have, not all institutions in the United States have FISH for isochrome 12p. We have it, so often for myself, because these are rare and sometimes difficult, I will often do the FISH isochrome 12p in an older male to verify it's a prepubertal type teratoma. This is an example with these multiple squamous cysts, all benign looking, surrounded by glands that look very benign as well. This, is probably a familiar sight. This is from Saudi Arabia. So I mentioned scars in the testes. When you see a scar in the testes, your choices are, is it trauma, infection, infarct, which can end up being a scar, or tumor regression. And of all of these, the most important one to recognize, is this a regressed germ cell tumor? Because these patients have to be followed, have imaging tests. They might have metastases already in the retroperitoneum. Now, trauma, most of the time, in order to result in a scar in the testes due to trauma, you don't get trauma to the testes, instant minimal trauma to result in a scar. It should be a significant trauma that there should be some history of that. But here we see a germ cell tumor, a teratoma, which is still areas of viable teratoma, but you can see large areas of it are already starting to scar out. So sometimes you can see partially regressed tumor. But here, this was a case that there was only this scar. There was nothing else, just a dense scar. But when you see a dense scar that's wiped out the seminiferous tubules, we don't see any outlines. These are not just atrophic seminiferous tubules. It's a dense scar. The first thing I think about is regressed germ cell tumor. And when you look at that, the next thing you want to do is, what does the surrounding testis look like? Because germ cell tumors, typically the surrounding testis will have Sertoli-only pattern, or may have sclerotic seminiferous tubules. There's something about germ cell tumors, that cytokines that they secrete, that result in impaired spermatogenesis in the surrounding testes. Not just immediate to the testes, it's not just a compression artifact, but it's actually diffusely through the testes. So when you have a scar, if the surrounding testis looks abnormal, that's another feature favoring that this is probably a regressed germ cell tumor. And here we see Sertoli-only pattern next to a scar. Again, highly suspicious this is a regressed germ cell tumor. That last case I just showed you with the scar, this patient presented with metastases of seminoma to the retroperitoneum. And that's often how one finds these regressed germ cell tumors. They can have huge, bulky retroperitoneal metastases. Then basically the testis feels normal on exam, but they do an ultrasound, they see a little scar, and that's end up being the regressed primary. This is what I mentioned when you see these dense, coarse calcifications. That's also favors strongly that this was a regressed germ cell tumor associated with a scar. Now, if all I see is a scar, some calcifications, the surrounding testis shows an abnormal spermatogenesis, what I can end up saying is that's highly suggestive of regressed germ cell tumor. I can't be 100% definitive unless there's metastases. If I find germ cell neoplasia in situ next to a scar, which is what this image is, then you can be specific and say, yes, this by definition had to have been a regressed germ cell tumor. Here we see the scar. Here, next to the scar, one can see some germ cell neoplasia in situ, and you can make a definitive diagnosis. This is also Vietnam. And then actually, the adenomatoid tumor we're not going to talk about now because I'm going to show you a slide seminar with that. So we'll hold off on that one. We talked a little bit about this yesterday, mesothelial proliferation in hydrocele versus malignant mesothelioma. I'll cover that a little quickly. Again, in hydroceles, you get this linear array of reactive mesothelial tubules, as shown here. Cytologically, they're going to be bland, linear in between the dense fibrosis and more inflamed tissue. But they can be quite proliferative, forming tubules, sometimes even little papillary formation. Not overtly malignant, but malignant mesothelioma could look like this. In contrast, malignant mesothelioma of the tunic albuginea typically is quite obvious. It's usually going to form a big mass, just like you see here, tubulo-papillary, typically overt malignancy. This one's invading the testes, going around seminiferous tubules. So most of the time, very different than just reactive mesothelial hyperplasia in a hydrocele sac. Again, invading the testes. Last one we'll cover is seminoma versus a large cell lymphoma. Important distinction. Large cell lymphomas tend to occur in older individuals, but again, there can be some overlap in terms of the age, so you can't rely on the age. The key thing is seminoma cells, as we've gone through, are more uniform cells, rounded cells, more open chromatin. Lymphocytes look benign. Lymphomas, the nuclei are much more variably sized and shaped, not the nice uniform cells. You may see some sprinkling of lymphocytes, but these are much more pleomorphic. Now, typically large cell lymphomas can also kind of invade in between seminiferous tubules, similar to intertubular seminoma, but the cytology is again different. You don't have the cleared out cytoplasm and the greater degree of pleomorphism. Another example of this was an unusual lymphoma that had a clear cytoplasm, which is rare, involved in the testes, but still the nuclei are not the classic seminoma nuclei. So the pitfalls is seminoma, as I mentioned, usually occurs in younger men. Lymphoma is older, but there are exceptions. The key thing is to think, could this be a lymphoma, do immunohistochemistry. OCT4, you have to be careful. There are some lymphomas that are OCT4 positive, but basically almost all lymphomas in the testes are going to be B-cell lymphomas. They'll be CD45 and CD20 positive. Diffuse large B-cell lymphoma, OCT4 is negative, or I should say OCT4 is positive in this case, showing you why, again, you have to be careful with OCT4, but the CD20 is diffusely positive, telling you it's lymphoma. But seminomas would never be CD20 positive. And with that, we'll deal with Sertoli cell nodules. We can deal with it now briefly. So it's not uncommon in testes to see Sertoli cell nodules. Often in cryptorchid testes, these are not tumors, they're more hyperplastic, and they can have two different morphologies. One are these seminiferous tubules. They look like seminiferous tubules lined by these columnar cells, but they have these very dense pink secretions in them, often almost forming little cribriform structures. The other pattern of Sertoli cell nodules are when they look like immature seminiferous tubules, reminiscent of what you would see in a fetus. In contrast to, these are the adult seminiferous tubules. And they form these multiple nodules. They can be sizable, but as long as they're multiple or they have these morphologies, you don't call them tumors. These are just Sertoli cell nodules. Here at higher power, these immature, in a Sertoli cell nodule, these packed, immature little nests that individually look pretty indistinguishable from neonatal seminiferous tubules. In contrast, this is a Sertoli cell tumor. And Sertoli cell tumors typically have a very bright pink collagen matrix. And then, by definition, most Sertoli tumors will have some tubular differentiation as well. Here we see these little nests of cells with this dense collagen. And classically, Sertoli cell tumors will have that just central nucleolus, just like normal Sertoli cells. And here we see them forming tubules. Another example of Sertoli cell tumor, forming little cords of cells as well. And for sex cord stromal tumors, and this will be the last slide I'll show, for the criteria for malignancy for all sex cord stromal tumors, whether it's Leydig or Sertoli, are the same. You need to have at least 3 of these features, either over 5 centimeters, which is huge in the testis, significant nuclear atypia, very hyperchromatic pleomorphism, increased mitoses or vascular invasion, widespread invasion into the testes, or necrosis. There are sometimes you may only see 1 or 2 of these atypical features, and in that case, if it's a Sertoli cell tumor, you would call it an atypical Sertoli cell tumor. And if there's only 1 or 2 features, I would end up saying I would favor this is going to behave in a benign fashion, but still have patients should have follow-up. And with that, I'll end this lecture. Thank you very much. The next lecture is going to be kind of the bread and butter of bladder pathology.